Thanks, Tanya. Hello, everyone. Welcome. I'm just always thrilled to see such great attendance for our community conversations. Each of our talks really has centered around such important topics. And so today we have an excellent panel of contributors. I think we have a wonderful topic in cultural safety. We really can't ask for anything more, and really in the spirit of community conversations, this really is a meeting place to talk about some of the big issues within CFHA, whether it's something regarding treatment or even something on a much larger systemic level. So again, I want to thank everyone, welcome everyone. Feel free to post comments, questions in the chat as well as we go. And what I'd like to do is just turn it over to Martha, who is going to orient us and give us a really great introduction for everyone that's in attendance today. Thank you, Martha.
Thank you. Thank you, Corey. So welcome, everyone. I am Martha Saucedo. I'm the project manager for technical assistance and strategic development here at CFHA. And before I introduce our wonderful panelists today, I wanted to pass it on to Mion, who's one of the co-chairs of the Just Medicine Committee, who very graciously are hosting actually this particular topic event today. When we started talking about the cultural safety concept, and we thought it would be a great way to have a community conversation about it. So Mia, why don't you tell us a little bit about the Just Medicine Committee?
Thank you, Martha. My name is Mia Yoon-Hammer. I am the co-chair with Tanya Vishnevsky, who was unable to be with us today, but we're co-chairs of Just Medicine Committee, which is a committee within CFHA, and really our efforts are to reflect the commitment and the interests of CFHA in regards to making sure that issues of diversity, justice, equity are very much in the forefront, in the center of everything that we're doing as an association, that it's not an additional thought or an added thought, but we're really seeking full integration. We want to work ourselves out of a committee where CFHA eventually becomes an association that intuitively and organically is thinking through and seeing through a lens that is inherently one that understands systemic issues and is really making an effort in all aspects of our association and the ways that we represent healthcare to be representative of a more just system, a more inclusive and equitable one as well. So thank you for this conversation, Martha. Thank you for your leadership in really gathering these folks and making this happen. So without further ado, Martha, take it away.
Thank you. Liana, can you support us with the slides? As I kind of start mentioning to everyone, I'm actually not in my regularly office right now. I'm actually on vacation, but I couldn't miss this conversation. That's why I'm here. And I actually needed some support from Liana to post some of the things. I'm using all my screens here. But I want to start. We have 4 people in our panelists to start our safety our cultural safety conversation, and I'm gonna talk a little bit about them, and then what we're gonna do is wanna briefly discuss what cultural safety means, because when I first heard this topic, it was very new to me and I really needed to go and research about it, and that's when I thought it will be interesting to have this conversation today. So then we will talk a little bit about what it is, cultural safety, and then we'll open up to have the conversation. So first we have with us David Humphrey, who has worked for 25 years as an independent family therapist in a primary care medical practice in the United Kingdom. He provides consultancy and clinical supervision to social prescribers in a group of practices in Hertfordshire. David is on the staff at the University of Exeter, involved in teaching and training family therapists. He was awarded as a Churchill Fellowship in 2016 and spent time in the United States and Canada observing a variety of primary care settings. He has a strong interest in research, evaluation, and service development. And David has always been very passionate about the work at CFHA and the development of equitable integrated primary care in the United Kingdom. Thank you, David, for being here with us. Then we have Paddy Robinson, who is currently the Director of Training and Program Evaluation for Mountain View Consulting Group. This company was founded in 1998 and is a recipient of the APA Presidential Innovative Practice Award. Dr. Robinson is a co-founder of the Primary Care Behavioral Health Model and Focus Acceptance and Commitment Therapy. She provides consultation and training services all around the world and is committed to improving access to behavioral health services and to the realization of the health equity. Early in her career, she worked as a researcher and a clinician for Group Health Cooperative in Seattle, Washington, and as a behavioral health consultant for Yakima Valley Farm Workers Clinic in Toppenish, Washington as well. She has over 15 professional publications, including 11 books. Thank you so much, Paddy, for joining us this morning for you and me, still here in Arizona. We also have Amber Landers, who is a clinical psychologist with experience teaching, consulting, and providing brief interventions in community, hospitals, and school settings. Her interests include integrating mental health into non-mental health settings, reducing stigma and implicit bias, and promoting health and mental health access for underserved populations. Dr. Landers is currently an assistant professor, assistant program director, and coordinator of the Integrated Health track at California School of Professional Psychology in San Francisco Bay Area campus. She has recently co-authored a chapter on depression in the textbook Pediatric Mental Health for Primary Care Providers and continues to consult to agencies in the Bay Area. Thank you so much, Amber, for joining us as well. And lastly, but not least, we have Julie Green, who is an Eastern Band Cherokee and African American associate professor and clinician. She has taught for 8 years in the Clinical Doctoral of Psychology department at the California School of Professional Psychology, Allen International University in San Diego. Dr. Green is a past president of the APA Division 6, Alaska Native American Indian woman, and current program member at the large of Division 45, ethnically diverse, as well as the Association of Black Psychologists, and has worked in community mental health for over 14 years. She conducts research and advocates in the following areas of intimate partner violence, Native American women, women of color, and social determinants of health, indigenous feminist focused mentorship, as well as strategies to recruitment, retention, and assist with the matriculation of ethnically diverse graduate psychology students. So as you all can see, it's a great panelist to start this conversation. And I want to pass it on, like I mentioned, to David, so he can talk to us about what is cultural safety. I think for a lot of us, this concept is really new. So David, why don't you tell us a little bit more about what we can find when we Google, what we found that it's actually cultural safety. We can go to the next slide.
Okay, thank you.
Diana, yeah.
Okay. It might be useful for me to say initially how I came to being here today, really. It grows out of the conversation I had with Martha. And she basically asked me whether I'd ever heard of this idea in the UK. And I heard, and in a kind of tangential way, I'd heard about it because of my sister. My sister was the director of training until 5 or 6 years ago at a nursing department in a university in the UK. And several years ago, she had been talking with me about this idea because it was actually a relatively new idea in about 2016, 2015. So when Martha spoke to me, I talked with Anne, my sister, and what became interesting in that conversation is that somehow the idea of cultural safety had almost disappeared. It disappears and it almost emerges, transformed into an idea of cultural competence. So now in nursing, there is a requirement, there is a module called cultural competence. So I suppose for me, the first idea based on and I'm not an expert in any sense, I'm just simply somebody who has tried to look and to understand and to kind of pick up some ideas. But that first idea about power imbalance seems to me in itself to be quite significant when we think about the kind of transformation that somehow cultural safety, which is about acknowledging the power balance, somehow gets turned into this idea of cultural competence. And when I checked just before I came on today, what's happening currently, I looked at what's called the Royal College of Midwives, and they are currently running something called cultural safety or country competence and safety. And what it really does, it doesn't mention power. Power is not described. It's not acknowledged. It is, there's talk about biases, there's talk about values, all of which seem to be very, very important. But power and the power that the provider holds, both in terms of their entitlement, their cultural entitlement, and the way that that power is used culturally, and by virtue of their status as a healthcare provider. So it seems to me that in this particular slide, the real issue for me is the acknowledgement of the power imbalance and what that power imbalance means, which is why in the last part, in contrast to cultural competency, the focus of cultural safety moved to the culture of the clinician or the clinical environment rather than culture of the, in quotes, exotic other patient. So for me, that's what I take from this. It's the acknowledgement of the power. Could you have the next slide, please, Martha? Thank you. In this one, I guess I pick up what I took from it was I picked up on those ideas, and I emphasize in that first point, which is the notion of power, and an acknowledgement that power does have varying interpretations within and between countries. But I think the other aspect which comes out for me and by my reading and my thinking about cultural safety, which when I look at this slide, I realize I probably don't capture enough, is the patient's experience of safety. The patients, we're used to using lots and lots of outcome measures. I think most of us is what we do. We check people out at the beginning. We run this measure, that measure. We're very good at running outcome measures. Certainly as a therapist, I'm doing that all the time. But actually, this seems to be much more fundamental. It's consulting people about safety, whether they experience this. What does it mean for them? What is safety? And in that sense, I think requires us to think quite differently sometimes about how we approach people. I'm not going to say very much. I'm not hopefully that's useful. There are more slides which Martha has got. They've got more reading. They've got some references. These are just simply thoughts that I've currently got, in a bid to kick off a conversation. So it's over to the rest of us, I think.
Yeah, thank you, David. I think we can remove the slides for now, Liana, just to see everyone's face. Great. And with that, I think it really brings, it makes me think about even how I, as an immigrant in the United States, have been feeling in my medical setting, right? If I feel safe sometimes, and definitely in our culture, from the Latinx culture, it does bring that power in which we are go up to actually believe that whoever has a degree or studies or is in a place of being a professional that you are not involved, that person will know better than you, and that you always have to either approve or be okay with that. And so it's definitely a strong power relationship that it's involved. And a lot of the times, not because it's in a power relationship means that the patient is always feeling comfortable, right? So a lot of times it's you assume, but there's sometimes that you don't feel comfortable with. So I'm curious to kind of, again, open the conversation. And Paddy, do you want to let us know a little bit of what are your perceptions, or what do you think about this concept and the importance to have it around or not, particularly in healthcare settings?
Sure. No, I think the idea of safety, it's really important. And I certainly, as a biracial person, would not go to a healthcare provider that, or a second time, unless I was really sick, if I didn't feel safe with them the first time. And that kind of reflects where we're at in healthcare, because people don't feel safe. And so we see people from different minority groups using healthcare less and experiencing more health problems. So it's of fundamental importance. And I think I'm really glad to be a part of this conversation and see this start in the United States. And I want to say that in 2016, I began a conversation with Kiwis in New Zealand about health equity. And that's a country that way back when started caring about repairing the harm of colonization and creating health equity. And they've tried many things to create health equity. And it's been a real privilege to work with them and assist them with integrated care, development of integrated care as a way of pursuing greater health equity. And they are committed to following the data and experimenting and innovating. And they've done did a proof of concept study, and then did a national study, and looked at primary care behavioral health services and their impact on health equity in general practice or primary care settings. And they found health equity and equity in terms of access, with Maori and Pacific Island people accessing care at the same rates as European population. They found health equity in terms of outcomes with, for example, Maori reporting 71% improvement, compare 74% improvement in receiving services from a behavioral health consultant, compared with 71%, the overall population. So it can be done. It can be done. It's not easy. It's not perfect. It's growing and evolving down there. It's will be difficult, I think, in some countries more than other countries. But there, the Ministry of Health decided to fund primary care behavioral health services after their national study in 2019. And they're about 65% there right now. So they have over 200, they call them health improvement practitioners rather than behavioral health consultants. And they have iwi health services or Maori health services working to help us get better as we're scaling up. so that was one comment I wanted to make, is just we can do better, and other countries have, and they've shown the way, and this has been published. We need to look at this and learn about it. But the other thing I just wanted to say was more on a personal note, and how humbling it's been to just try to reinvent myself as a psychologist, and how much that's required me to give up on my professional identity that I learned in my education, and to learn to be vulnerable, and to introduce myself in ways that promote relationship. So in 2002, I left Seattle and my research team there in order to kind of just immerse myself in rural healthcare in a clinic that was serving Latinx people and Yakima Nation people, and everybody else that, you know, came there that was in a part of this community. And I worked hard to develop a way of relating to people that I would see that was respectful, based on respect. And so I think respect first for me meant giving up on the idea of being an expert on them and able to diagnose them and prescribe a treatment for them. And that's a big shift, to move from diagnostic based kind of assessment and intervening to functional based assessment and intervening. And I've written about that, and I think it's the way to go, but it's not an easy path to take. It's always hard to have that equal kind of relationship, and to go with humility first. We're just not trained that way, and we don't really work that way as humans. It takes training to be that way, to be able to be vulnerable, to not know, to maybe introduce yourself in terms of your relationships with people and with the land, as opposed to your degrees. It's a whole different way of relating. Yeah.
Yeah, that's so powerful, Patty. Thank you for sharing that. And I think I agree with you. I think one of the times that I have having a very good relationship with patients in rapport base, it's when I'm able to be humble and express also my own experiences, instead of coming with that I know it all hat and I'm the professionist here. So I completely agree with you in that one. And it takes a lot of work, and being, like you said, being humble.
Yeah.
People can feel unsafe sometimes. And it takes a lot of practice, definitely.
Yeah.
Amber, give us your thoughts in this topic. When you hear about, the cultural safety concept, and we invite you to this conversation, what were your thoughts?
Let me unmute. Yes, thank you for inviting me to this conversation. So when I think about kind of the initial request and the topic, when I read it, like just cultural safety, I thought, I think I know what that is, right? And then you sent the article, and it took me 3 hours to read the article because I was taking so many notes. And if I had a highlighter and I wasn't reading it on my computer, the highlighter would not have helped me, because the whole thing would be yellow right now, because everything just gave words to so much that was important and so much that I realized I didn't know what this was. I mean, I knew what it was in theory, but I didn't know what cultural safety referred to. I was thinking about psychological safety or comfort or, you know, those type of terms that have to do with cultural competency and awareness, which is not the same thing. And so I'm so glad I was brought into this conversation. And I'm so glad that I had an opportunity to read the article to really, again, put words to power, right? Power. And a need to look at power in all these different ways, kind of, you know, reminds what Paddy is saying in terms of our roles and our relationships with people, our assumptions, right? And then the actual structures. And it had me thinking about the way things are set up in healthcare, therapy and medical, to place a power differential, right? Even notes. I remember when I was in an organization and we were starting to go to open notes, and there was like, oh my gosh, patients are gonna see their notes. They're gonna see their own information. Like, what are we gonna do? Oh no, right? And it's like, well, why? Why shouldn't patients be able to see their own information, even about their psychological care? Like, why is it a secret? You know, so, you know, giving that power back and just a reminder that people are should be in charge of their health and should have a say. And the way we interact and the structures that we are in need to be better at allowing for that. And so it also had me think about a couple of things. It had me think about my students, the things that I teach, and we talk about power in terms of therapy, but I was thinking, like, I'm not sure we talk about actual structures. We talk about power in terms of, like, you have this degree, don't go in there thinking that you know everything, like, find out about your client, don't overgeneralize, la, 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 la. But I'm not sure we actually talk about, like, structures, right? Like, when you walk into the room, what does it look like? Are you standing? Are you sitting? Are you making eye contact? Are you not? How did they get there? You know, they had to go through this whole registration process, and you came out there and you called their name. Like what does that feel like, right? Yeah, how did you introduce yourself? How do you talk about the note, right? Do you share that with them on the spot, right? Do they have to jump hurdles and go to medical records and make all these requests? How do you find out what's working for them or not working for them? And the biggest thing for me that I was thinking about, do you get annoyed when your client starts asking you questions? When your client starts making requests? When your client wants to see your note? When your client wants to know what they should trust you? When your client wants to know what your experience is? Like, do you get annoyed? And if you do, why? Why should they trust you? Why should they walk into a room and talk to a stranger and trust that stranger to know or care anything about them, right? And so it had me thinking about all these things that I want to embody better and that I want to pass down to my students better. And then it had me thinking personal, like personal experience. So I've, worked a lot in healthcare. I had positive experiences. I was a behavioral health clinician. I was doing consultation. And I think I took for granted that I understood the inner workings of the process until I had my baby. So I have a toddler. And I knew intellectually the research on Black mothers and this and that and pain management and chronic pain. And I thought I was immune because I knew it and I have a doctorate and I research it. But it happened to me. And I think that because I thought I was immune, it affected me in a way that I didn't expect. And this was all about pain management, right? Like not being believed, right, about my pain levels. And when you're in a room in a gown, no one knows or cares about your degree, right? Yeah. You're just a person in a room in a gown saying stuff that no one is listening to. And so I think that also brought a reminder, right? And an awareness that nobody's immune, right? And that this word, cultural safety, sits with me stronger now that, I was expecting equality in this room because of the stuff that I knew, right? Like, I'm a professional too, and you're a doctor, and like, hey, we have this thing in common, but you don't know that about me. And so the power piece was so salient. in my own experience, that it was a reminder. I'm almost embarrassed that I was surprised. Like, why am I surprised about this? Like, why was I surprised that that happened to me, right? Why would I think that I was immune because I have 3 letters behind my name, right? So I really, I'm excited about this conversation. I really want to hear what other people have to say. And I'm really grateful for learning a term and how it applies and being able to think about it in my work, in my personal life, and how to pass it on to students. I took so many notes and I'm like, I'm gonna bring this in my class. I'm gonna have them read this, right? We're gonna talk about this because we need to understand power and all its different forms, and especially the way that it just kind of can sneak up on you, right? Sneak up on you as the provider, but also as the client, the patient, the other person in the room who's coming in with, their life, right? We have one life to live. Why would I trust you with it, right? So that's where I'm at with that, and I really appreciate being able to start this conversation.
Thank you, Amber. I really love when you mentioned that it was not until you were a patient you were able to see things so differently, and that's so true. That's so true. That is not until we kind of switch the roles, things can be seen with a different lens. Thank you so much. Julie, what do you have to tell us? When I invite you to this conversation and, we were all talking about this is new, we haven't heard this concept before. Tell us your perspective.
Yeah, I'm doing so much head nodding over here. Amber, you see me like an amen quarter saying, yes, yes, yes. All the things, yes. So again, I appreciate the invitation to the corner. I had similar inklings that Amber and Paddy shared. I'm feeling like, oh, I got this. I've been involved in this area, cultural competency. I teach this in my class, so I must know this. I must know this, right? No. And it was one of those like moments of like, oh, this is a different area here. Yeah, I know pieces of this. So pieces of it resonated with me when I read about it. So in reading, again, it was just when you introduced the articles, when you asked me the questions, I read it and was like, oh, that's stimulus value. Oh, that's what we bring into the office. Oh, that's how we navigate these spaces. Oh, that's right, that power dynamic that is inherently involved in the system and how it manifests and in what we do as clinicians, or how it manifests and how we engage with our clients. And that piece, that critical piece that you share, Amber, that I am teaching my students, but I am not like helping them to see how it's practiced, right? And helping them see like how, right? So you might be involved in this way, and then how you're also experiencing this too as a student, and whatever, you have this power dynamic here, and then you don't have this power dynamic, these other spaces. What does that do? How does that shift things? How does it feel, right, to engage in those spaces? So again, it gave me a different appreciation and fueled a fire in terms of like how I need to change up how I'm teaching this, and then maybe again examples that I might use to, and like personalized examples that could click at least, or that might be helpful in terms of sharing, but also activities that I might be able to implement in my class to help them at least resonate or align with a little bit more. So that part of me, the creativity and how to help connect my students to this, and new articles that I can share with them that are actually within the last 10 years that will be relevant for their learning. And my hope, again, my whole goal in teaching is to help curate new psychologists who are out here, who are more informed than I was, than the folks who trained me were, and that do better, and that like do our profession better, because there are so many harms that psychologists, that other health professionals, that we all have engaged in, that, and there's not enough like this reparative action to actually address the harms, right? There's not enough folks in here saying like, okay, the damage is still being done. This is the ripple effects of this. So leaning on, right, indigenous ways of knowing that have always been in practice, right? That folks are curating, saying like, here's what this is, right? These things work, because there's maybe, there's not literature around it. There aren't ways that folks, have measured this. Then, right, the powers that be and folks who gatekeep, right, and don't necessarily say that this is valuable. So maybe think about systems that are in place. So there's a native entity in Minnesota that they've been able to build for medicine wills, for adapting certain cultural practices that are aligned with like their traditional values, that might look like, coping strategies, but they're utilizing sage to help, cleanse, or utilizing just different cultural practices to help address their health and mental health needs. And they're integrating their practices and being able to use Medi-Cal to pay for these things. So like if we can develop, systems and align our practices that maybe, implement, sorry, now I'm getting off track, but that might be more aligned in that way. Like those are the things that my hope is, in terms of like how we can move ourselves forward.
That's great. So I know some of the panelists have been talking about some articles that we shared in order to have this conversation, and we will definitely share them with the attendees as well in this conversation, so you can read those articles and see what we're referring to. But I think also, Amber, you mentioned something that it kind of clicked on my mind in when you said about the systems, right? So it seems like, and Paddy mentioned that this has been done well in other countries and they're advancing and doing it, but it seems like the system in the United States, it's different, and we haven't really heard or pay attention that this needs to be considered. And the first thing that comes to my mind is, what do we need to do, particularly us that we work in healthcare entities, in order to start looking into those things? Because this is a group that haven't heard this concept before, or for the first time, or we know that it has been done in other countries, but not here. How can we move forward to start making this group bigger, but also changes on the system? Any thoughts?
One thing that I've been trying to do and finding challenging, but I like it because it's a very frequent reminder of that power differential and that challenge to be vulnerable and to relate to people as people. In what I've been experimenting with is, rather than calling people that I serve, and I do say that word serve rather than treat, people that I serve, referring to them as people, or individuals, or families, rather than patients or clients. And it's a big shift.
That's helpful. Yeah, definitely. Anybody else thinking, or even some of the audience that is listening to this conversation, any thoughts as to, when you're hearing about this concept and the ideas as to where we need to move forward, how can we start making that shift, even if it's in little baby steps, because that's how change is created, right? One step at a time.
So for me, I think about some ideas around like radical healing. So where we do, like, it is engaging in principles and pushing the boundaries, like those little steps that I can take is integrating this in my classroom, right? Or thinking about this on committees that I'm a part of. So making it an evaluative component of how like we operate, right? So I'm on a diversity, equity, and inclusion subcommittee of my within my department. So some principles can be aligned with how I operate or how we work as a group. And I think those little shifts can help bring about change. Or when we're in positions of power, or or in positions of rate about equity and inclusion, like we actually infuse those things into how we operate. And that's where little changes can occur. And I think that being involved in this group is a great way to brainstorm or think about how it's implemented too. So thanks for that.
So Julie, that reminded me that when I actually brought this concept to the Just Medicine Committee, one of our members, Ebony, had never heard about it and started researching about it. And then I think I shared this on a Thursday or so. And then the following week, she shared that because she's in a position of power in her agency, she was able to change all the language based on cultural safety now. in their agency and starting considering, instead of, even moving from cultural humility to actually cultural safety, which is, sounds different, right? So I was very inspired by that, how just even a conversation even create a little change in the system. But I do believe it's, we all together making these little changes that then we can start expanding and, to further go to where we want to be in the future, or improving our services in order to make people feel safe when they're taking, particularly when they taking care of change and that safe feeling for them, as it happened with Amber, like then she was a patient and maybe she didn't feel exactly safe, but so she experienced that. So we definitely want to turn around that, because it's not just for our patients, or like Paddy was saying, that people that we serve, but also it's going to be when we turn around, it's going to be also for us. It's going to also be our turn, and then we can feel safe also in their healthcare settings as well. I'm reading here a comment from Mariah. She said the acceptance of other paradigms and perspectives of health outside of the medical is monumental. Definitely, absolutely, for sure. And one of the things that it brought to my mind that I actually discussed with all of you when I met in order to plan this conversation was that it really was based on indigenous people. But then I was thinking about, what about other minorities and people of color? And David very beautifully labeled it in the beginning, that it's basically that relationship of power, right? It doesn't matter, if it's an indigenous people or any other people of color, but it's that power relationship that can really impact the care that we're having. So it's important to not just focus on one group, but generalize to, in general, everyone, and how they feeling in that power relationship when they're taking care, for sure. So David, tell us a little bit of what your sister shared with you when she was working as a nurse and they were implementing this. What was the benefit around their medical system when they were doing this?
I think several things. I think certainly here in England, in the UK, there'd always been, I think, a kind of an idea of what I'm going to call cultural competence. And I'm sure for nurses that's probably true in most countries. And it would be typically around things like death, when people die, if they're from a particular culture, this needs to happen, that needs to happen. And those things, in a way, had always been there. But I think what I think happened for my sister is recognizing that idea of simply thinking, oh, this person comes from that culture, therefore they're going to eat this sort of food and they're not going to eat that sort of food, or they're going to need to eat. That's this whole kind of idea of kind of cultural competence, which isn't anything to do with safety, really. It's to do with a kind of almost a tick box approach to it. And I think for my sister Anne, I think what happened is it really challenged that for her in terms of thinking about it, because I think things had become, certainly in nursing here, and when she talks about it, had become very comfortable. It was, we kind of know what we're doing. We've got this idea and we do this really well. And she ensures that her students were always very familiar with those kinds of things. But actually, once you start to talk about power, once you start to talk about the power that is, and when I think about it, for me, and I think when we were talking about it, the power is, I think it's one of the things that was coming up as other people were talking. I think Amber picked it up amongst other people, which is the power is hierarchical power. It isn't simply the power you as a healthcare provider can exercise, it's where you fit in the hierarchy. So one of the things that Anne and I talked about was that there's a very steep hierarchy still in the UK. I mean, the medical hierarchy. It's one of the reasons I was so attracted to CFHA and the US is because I read the stuff about the dual optic way back, and it was like refreshing. It's difficult to convey it. There is this idea of authority, and that the power ultimately rests at the top of the top of the hierarchy, which is almost invariably medical doctors.
David, I didn't catch one phrase you used. You said, I was interested in America because I read about what was
the dual optic. I remember, I can't remember who wrote, there was a paper written way back. This is what captured me. I read about a dual optic. It was, who was it? I can't remember. It's that idea of, it's described so beautifully in this paper of trying in the integrated care model to get a much more equitable arrangement between the behavioral health clinician and the physician, that kind of sense. And that for me was quite crucial, because it's not the case here. It's difficult to, maybe this would convey it. When I worked in the NHS in adult mental health services, there were PCPs who I would write to about a person I was working with, who would not reply to me. They would reply to the consultant psychiatrist. So they wouldn't reply to me. Didn't matter. One person, I wrote probably 20 letters, 30 letters over a period of 2 years, never replied to me, ever. Would always reply to the consultant psychiatrist. That's the hierarchy, and that's the stuff that Anne and I were talking about. That the power, it's both. It seems to me cultural safety is about recognizing that there is. The power isn't simply the power that you have as a healthcare provider or the structure within which you work, but it's also some sense that within this structure, there is this hierarchical power.
Which I think that's what Paddy mentioned in the beginning, that that from providers be very conscious about how are we thinking of a role, that it's really like breaking the paradigm that you were taught since you were training, right? The way I'm thinking is, when you're actually training for a PhD position, the way that you work as a mental health provider, it's very different than the traditional, mental health provider. It's completely a switch of change of mind when you're going into the integrated behavioral health. It's fast paced, you have to be multitasking in your role, your sessions are short, so you really have to switch your mindset. And this is kind of similar, in which we're trained to be the people who comes out as an expert, but really if you want to honor that cultural safety for the person that you are working with, you really have to change that mindset and come with, like Paddy mentioning in the beginning, with a more humble and vulnerable approach in order to be able to set that safety tone, in the room and in the conversation, and be able also to allow the person that we're serving to teach us, to let us know what they need and want, instead of us bringing with all this, like, I know this is next and this is what we're going to do. So it's really a mindset that needs to be changed. That can be hard because we're coming in an automatic mode sometimes. So it's important that we're aware of what are we thinking when we're coming, into the room with a patient. Like Amber was saying, like, what are you saying? How you're introducing yourself? How are you presenting physically when you're entering into the room with the patient? All that really matters. And it involves a lot of insight from our part, which it's possible, but it involves work from our part, to be very mindful of that.
There was a study, I've got to go back and look at it again, but they went in and they taught a group of substance abuse providers. They taught one group acceptance and commitment therapy for, I don't know, 2 or 3 hours. And they taught another group cultural competence. And then they just observed the behavior of the counselors in relationship to people in this inpatient, I think it was inpatient setting. And the people with cultural competence reported more confidence in their ability to work with these people. We have a lot of stigma about people that abuse substances, so there's a parallel there, but they indicated greater confidence in what they were doing, and they talked to these people less. The people that got the acceptance and commitment therapy, they talked to these people and they said, oh my God, I'm so not competent. And I think the most terrible things about these people, but their behavior was engaging. So I think that's kind of what's in front of us is, it's a lot of work. It's a lot of work to work with our heads. Yeah.
Yeah. That's so interesting, to see that perspective, definitely. Amber, Julie, anything else that is coming up to your importance to be aware of and what we bring into the room when we're working with someone, but definitely how to teach others and ourselves to start making those changes, right? Because that's the main goal of these conversations, to be more aware of and start making those switch and changes in order to create safe places for the people that we're working with.
I'll go briefly. I'm thinking about like embracing the value around change. So if folks higher up aren't embracing, like, don't think this is important or a value, then the trickle down is not going to occur. I hope Amber comes back on, but so yeah, I think that it needs to be a commitment from the whole, or an understanding of like why this is important, or like here, set the intention, and here's how it's like we need to be, or being able to process about like why this is important, and is this a value that you are aligned with? Is this a value that our company or our group or whomever, like our community, is going to embrace? And then kind of working, right? So I think there's internal work that needs to happen, and then that external work too. So you're outward facing. So how we need to lead now? How, right? Is this a part of like our strategic plan and how we're going to operate? Like, so all of those things, right? Like you said, like if it's about embracing it, then it's about fully engaging in it. It's about fully adopting it, not making it a sideline piece, but really allowing it to be the whole. So, yeah.
Well, and that actually brings the idea, the comment that Sarah commented here about the way an agency policy support cultural safety for anyone on their grounds, right? So yes, it's a role from us, but also the people that we're working around, the policies are written. And then a lot of the times it's not just what it's written, but they respect and honor what it's on those forms and papers, right? Which sometimes you can find these connections there. Here, Sarah Potts mentioned something else. Is anyone aware of whether Valiant or other reflective types of healthcare staff providers practices affects awareness, support, and cultural safety? Oh, and then jump in, Paddy, if you want to reply to that.
I'm not an expert on Balin. I've just had a little bit of training, dip my toe in the water. And what impressed me was the level of acceptance by colleagues and all experience, and nothing was not allowed, and just how refreshing that was to just feel safe to be yourself with your busy, crazy mind going off and getting in the way. And that was huge. I was just like, watching. Yeah.
So I want to share that when I contacted Paddy in order to start this conversation, she brought to our email a word that resonated with me because sometimes I feel this way living in the United States as a Latinx woman. She mentioned sometimes you feel like walking like eggshells, right? And sometimes I feel that I actually feel that way in things I'm doing here. And that resonates to me of sometimes how the people that we serve can feel when they are coming to our settings. Like they're testing, is it safe to say it is not? Are they gonna take it appropriate or not? I'm gonna be hurt or not? And because I sometimes feel I function that way in general in the country when I'm testing things, if that's cultural appropriate or not, that really resonated to me as to how to understand how the people that we're serving can feel and be more in tune as to being more open as to making those questions if we actually make them feel that way, if they're really just testing and they don't feel comfortable, or it's actually the opposite. We're really being so welcoming and so open to let them know how they feel and learn from their backgrounds, their history, what they believe, in which they can be very open and trust us in that sense. And a lot of the times it can be maybe one person they trust in their healthcare setting, and maybe that person is us. You know, maybe it's us who's gonna trust in that setting, and just by that, it makes a big impact because we can be that catalyst to help them be supportive, but the other providers they're seeing in the clinic or other people they're working with. So we're coming close to the end of the conversation. I want to be respectful of everybody's time, but I really want to, just give a couple of minutes to give the panelists for them to give the last thoughts they have in their minds before we end up the conversation. David, anything you want to say?
I suppose one of the things I would say, and I think that was something that Patty, mentioned early on, is that I think that integrated care offers a potential. As of itself, I don't think it creates cultural safety, but I think it certainly, for me, is a really, really important part of it. I think without it, boy, it's a tough task.
Yeah. Thank you, David. Patty? I think you're muted.
Just leave you with a Zen saying, an open hand gathers more flowers than a closed fist.
Beautiful. Thank you, Patty.
Be gentle with yourselves. This is hard work.
Yeah. Amber?
Thanks. Sorry, I got kicked off, but I'm back.
That's fine.
Yeah, I just really appreciate this conversation, and I have a lot of things to think about. I even took notes. I think for me, it's expanding even beyond kind of America and kind of seeing, I've been inspired by some of the things that people have shared in terms of research, seeing what's going on in other places, and just kind of, again, this paradigm shift of just thinking differently and kind of being more aware of where the power is showing up, how it's showing up interpersonally and within structures and processes. So that's where I'm at.
Thank you, Amber. Julie?
I feel all of that, all of it. And mine is just the ideas around like radical healing, like what we can do, right? We can think and engage in these broad based things, and we can apply them in small ways that can help make change too. So I really feel inspired by this space, and thank you again for cultivating this.
Well, I can't thank you enough for the four of you and everyone who joined us to this conversation. Definitely, I'm on vacation week, but my highlight of the week was this conversation. I really, really enjoy it. Thank you so much for joining me, for making us start talking about this. And I really hope we can continue this conversation, and each of us, we can create that little change in our own places, in our own work, to start making healthcare settings more safe for everyone and for us as well. Thank you so much, and enjoy the rest of the week. Bye, everyone.
Thank you. Thank you.
Bye. Thank you.
Bye-bye.